We're going to talk about the fundamentals of communication for sonographers, guys. How we're communicating with our patient, what makes communication important in sonography, and just different ways to communicate with different cultures. Okay. So, some of our objectives include obtaining basic human needs and the grieving process, learning about that. Recognize the importance of communication and patient care. Oh, goodness, I'm kidding. Appreciate the need to recognize and accept cultural differences. That's the great thing about our classroom, is that we're so diverse. And so we kind of get that opportunity before we even get in the healthcare setting. Okay? Recognize the vital role that effective communication plays before, during, and after each sonographic exam. All right? So, guys, every Monday, my boss, or our big boss, Mr. Omar Reed, if y'all met him, right? Mr. Reed? Dr. Black's boss. That's who Mr. Reed is. He's over HR, the VP of Harris Health. Okay? He sends out Monday motivation every Monday. And so usually I always read them. I used to share them with the students all the time, but I want to get back into it because this one applied to us today. I wanted to incorporate in this lecture. So, giving comfort. This was the name of today's Monday motivation. Okay? When we can be useful to others, rather than merely hoping that they will be useful to us, that's supposed to be us, we are better people forward. What's more, we are happier. Okay? Now that's just like saying, whenever you decide to give something, give with a giving heart. You know what I mean? Don't expect something in return. Basically, when you give with a giving heart, I would say, is you feel more rewarded for it than, let me do this because I'm expecting something in return. And then you get let down because everybody doesn't react the same way you do, right? So just because I would do something a certain way, that doesn't mean somebody's going to do it for me back the same way, right? Because we're all different. So I really like that. So whenever you give in comfort, giving anything, always give from a giving heart. All right? To understand others, we need to really listen to them rather than make assumptions or hear with only half our attention because we're eager to make our own points. What kind of person is that?
Extrovert.
It's an extrovert, right? Okay. So when you're talking with, the reason I picked this Monday motivation because it really applies. When you're talking to a patient, you have to listen attentively. You have to be an active listener. Make eye contact, shake your head, nod yes, make sure that they know you understand them. Repeat stuff back to them. Make sure that they feel like they're important. Because all of that matters when we're talking about patient care. And again, remember, by the end of the day, your money is affected by the patient satisfaction. So always treat your, not only that, not even about your money, but just general as a person. Like I said, I believe you give back what you put out. If I give good energy out there, you never know when you have to go to the hospital. Hopefully that'll line up. And then somebody give me that same energy back that I gave to somebody when I was getting healthcare. Okay? People have given me more comfort and understanding when I needed it. I hope that I can do the same for others. So just reciprocate it, guys. Somebody out there, if you out there giving somebody comfort, you can turn somebody's day from a bad day to a great day. They may go out there and share that experience and make somebody else's day better. And then that works. That makes the world better. I know I look at things from a big point of view, and I'm really a positive person, but I really believe that. When you give out good energy, people are going to feel it. They're going to feed it, and then they're going to give out the same thing. Remember, energy is neither created nor destroyed. It just turned into another form. So always, project that good, positive energy, guys. I sound like I'm a counselor up here. Let's get into this chapter, guys. So we're going to talk about communication, which is critical in healthcare, guys. Communication is critical. All right? Especially with sonographers, it's really important because you have such a responsible role when it comes to healthcare. The doctors rely on your findings and your experience, and also the patient. You're with the patient like 30 minutes, so you build more of a rapport than doing other exams that are real quick exams like an X-ray. Okay, so sonographers must be able to effectively communicate with patients in order to perform quality patient care, and to do so, you must understand basic human needs and the elements of the grieving process. God, this is stuff right here what I was talking about. If you took psychology, you already know about Maslow's hierarchy of needs, and you already know about DABDA, which is the stages of grieving. Okay? If not, we're gonna go a little quick review of it. So, Abraham Maslow described the hierarchy of needs with basic needs needing to be met before one can aspire to do more lofty needs. So basically, I have to meet my baseline needs. I gotta be taken care of, like, I gotta be nourished. I gotta have housing. You know, I gotta have those basic needs as a person before I can go up the different ladders of Maslow's hierarchy of needs. Okay, we're gonna talk about that on the next page. Or if you're looking on page 251, it's at the very top. Okay? So I just want, most importantly, I just want you guys to know, you have this, it's the same PowerPoint you have. That's the same one. I didn't even change one word on here.
Okay.
I just changed the color of the background. That's it. It's the exact same thing you guys have.
But the first page wasn't.
It wasn't. I just added that. I add stuff a lot. You'll see that.
I think you're gonna get into Maslow's, but we had a question on the homework concerning Maslow's.
Okay. What was the question?
It's basically talk about the second level of Maslow's hierarchy.
Let's get there first. Okay. So, most important on this page, I want you to know that Maslow developed the hierarchy of needs, and know that hierarchy, page 251. Okay. And Clayton Alderfer's ERG theory is similar to Maslow's. ERG meaning existence, relatedness, and growth. You just know what that theory is. Okay? He suggested that people can pursue and find motivation from needs at more than one level at a time. So while Maslow's hierarchy of needs saying that before I can get to the full self-actualization process, I have to go through these 4 steps. Clayton Alderfer, he's saying that I don't necessarily have to go through those steps in that same order. I can be at 2 steps at one time. Basically, he believed that. That's all I want you to know about this page right here, guys. All right? Sonographers interact with people who are working to meet varying needs throughout the day. Rather do sonographers meet people who are self-actualized? God, we'll talk about that in 1 second. I got a question to ask you. The majority of patients are likely in a state of illness, especially here at Harris Health. A lot of our people are already sick. You know, they already, stage 4, already having uncontrolled diabetes, high blood pressure, already have these diseases that are, debilitating. Okay? So let's talk about Maslow's. This is Maslow's hierarchy of needs right here, guys. We've all seen this before, right? In this form or another form, right? So we got to start at the bottom before we get to the top. We got to build this foundation first, right? Same thing with what we're doing in here. We're building that foundation, learning about abdomen, before we can go into more specific exams. Then we're going to build up. So the first level of Maslow's hierarchy of needs, guys, you see I have an arrow by it. That means what? If it's red.
Homework question.
There's a homework question. There's a homework question right there. Okay? So first, our physiologic needs must be met. Meaning our need for oxygen, food, water, rest, and elimination. I guess that's the one number 2. I guess. Okay. This guy, who made this book? Penny? Yeah, he went a little extra on the last sentence right there. The need for sex is unnecessary, but for individual survival. But it's necessary for the survival of mankind. Of course it is. Of course it is. All right. So we need all of those needs met before we can go to our security and safety. Okay. So that's the need for shelter and freedom from harm and danger. So we gotta be, nourished before we have that need to feel safe. Okay. Next after that, we want to feel love, the need for affection, feeling of belongingness, and meaningful relationships with others. Love, that doesn't just mean your family. That means people who are awkward. Sometimes they don't feel love because they don't fit in a social setting or what have you. You guys know all about that. Okay. Self-esteem. I'm just messing around, guys. Self-esteem, the need to be well thought of by oneself as well as by others. Self-esteem, how I feel about myself. Okay, and ultimately the last step would be self-actualization, the need to be fulfilled, learn, create, understand, and experience one's potential. Guys, how many of you guys feel like I'm self-actualized? Anybody here self-actualized? Anybody here self-actualized? I don't think I am, because I'm not fulfilled. I'm always trying to get better. That's just me. That's just me. You know, that doesn't mean that I just haven't reached that ultimate, man, I'm satisfied, I'm done, I can just chill and kick back for the rest of my half of my life, the second half of my life. You know, I don't feel like that yet. I feel like I'm still climbing, I'm still learning, I'm still developing. But some of us may feel self-actualized. You guys shouldn't, because you're in school right now. So you still working. You still want to be a great ultrasound. What's wrong with you, Jasmine? What's up with those eyebrows? We're gonna talk about nonverbal communication in a minute. Them eyebrows and that nonverbal communication states that it looked like what I was saying was nonsense.
No, I didn't say that.
I know, but the nonverbal stated it for you.
I think that you can be at a state of self-actualization.
I believe that.
So to say that you're not fully, I understand it.
That's
too,
what I'm
but I feel like
talking
you can
about.
be at a state of it.
Did I not?
No, you said none of us should feel like that. That's what you said.
Okay. I mean, fully
Right.
fully self-actualized. Then.
You got a state though.
Depending on, but I said you might, depending on your person. So since you in here learning, then that means you're not completely fulfilled because you're still learning. Maybe when you graduate, you had that fulfillment, like, I did that. I'm done. Let me do something else. But what's your question, Pat?
I mean, we could be at a place of contentment, but not fully satisfied.
Okay, I'm with that. Contentment versus fulfilled.
Yeah.
Whatever.
Self-actualization.
What was the question? You had a question.
Yes, as a matter of fact, we was debating about question 2 and 3 on the homework, but
I don't have homework in front of me. What are the questions though?
it was number 3. He answered it. It said the second highest level.
Right, the second
So
highest
that
level.
would have been
So
the self-esteem.
It says the second highest level?
it doesn't. I was
I
confused
must
about
have read the
that.
question wrong then.
Yeah,
So
it's
you
listed
have one on
second.
second
Also,
level.
it would be self-esteem.
The second highest level.
So I guess you want top up or bottom up.
Yeah.
It should be self-esteem, which is not on there. Oh, it is on there. It is D. That's the second high. So that's my bad.
But so can you
Self-actualization.
explain it then? Can you explain how it's the second highest level? Because when I was reading it, I didn't understand
Are you
how.
going from up to down?
Yeah.
So what is the biggest?
Because the physiologic, that's just the baseline. Those are just basic needs. I need to survive. I need to live. I gotta be able to eat. So that's our baseline. Our highest level is self-actualization. Me feeling fulfilled as who I am as a person. I'm satisfied. I'm out here, doing what I want to do, enjoying this life. It's beautiful, right? So that's our highest level of, of our human needs is being self-gratified. So our second highest level would be self-esteem, how we feel about ourselves, just based on Maslow's hierarchy of needs. Okay, because that's the bottom. Just based on Maslow's hierarchy of needs, it starts. This would be basically 1, 2, 3, 4, 5 from the bottom to the top. From the bottom to the top. Okay. So start with your foundation. That's number 1. All right. Think of these as steps. Think of these as steps. This is the top step. That's the bottom step. You're taking steps up every time. All right. I must have. That's why I put the wrong answer. I must didn't read the question clear.
It's good.
No, the answer's good. I'm talking about my red arrow here. I must didn't read the
No,
question.
that's the first second too. That's great.
Okay, I'm good then. I'm good. All right, guys. Let's talk about real quick. Any questions on Maslow's hierarchy of needs? Know who made it, Maslow, and know the steps. Okay. And also, when we're talking about the ERG, know who made that as well. That's all we learned so far today. That's it. Remember, I like to do this review at the same time we're doing the lecture. All right? So let's talk about the grieving process, guys. Grief is a normal human response to loss. Elizabeth Kubler-Ross and David Kessler described the grieving process in 5 phases. Know these 5 phases. Know our acronym for remembering these 5 phases. DABDA. Okay? Denial. This is how you're taught in psychology. They tell you to remember that. Denial, anger, bargaining, depression, acceptance. Has anybody ever lost any major loss that you all go through these 5 processes? Or may still be going through them. There's no time limit. Depending on that person, you still could be going through the grieving process. Okay? Just because you've accepted it, that don't mean I'm still not dwelling on it. You know what I mean? I've accepted the fact that my mom passed, but I still think about it all the time, right? Still a grieving process. All right? So know these 5 stages of grief. So that's like a patient comes in You know, I'm using this pregnant woman for example. We just got finished doing an exam. You know, we didn't see a baby's heartbeat. You know, we didn't see that. So she might say, in the first step of denial, hey, I just came to the emergency room, or I just was at my home health last week, and I seen the heartbeat. You know, because that's what she seen last. So she may be in denial, just like I told you about the lady that was in denial about her daughter being pregnant, because her daughter told her that she was a virgin. You know, so your first step would be denial. Next step is gonna be anger. You're gonna be angry that you're finding this out. Anger could be in the form of, you know, not necessarily angry at you, but just angry with the situation. You know, because you'll find people going through these steps while you're doing these exams. Okay? And bargaining being that, you know, oh man, what if the lady was a smoker? Or what if she was still drinking and her like, you know what, I'm gonna stop drinking now, so maybe that'll make the heartbeat come back. That's a person bargaining. Like for example, you have one of them bad nights out where you've been drinking and you wake up the next morning like, man, it's been a tough night. I ain't drinking ever again. Lord, please take it away from me. I do not want this hangover today. I mean, I had that feeling before, where it's like, man, I don't want to have another alcoholic beverage forever. Okay, that's bargaining right there. And then you go to the state of depression or sadness by you kind of coming around to the facts that, hey, maybe I went and got a second opinion, and I went back to my doctor and he didn't see a heartbeat either. Okay, then finally you get to the point of accepting what happened. You know, that don't mean you get over it, but you've accepted it. Hey, you know, I lost this baby. I'm having a spontaneous abortion or miscarriage. Okay, those are 5 steps to grief, guys. There's no data. Just know those 5 steps in that order. Okay, how someone processes grief can depend upon religion, culture, ethnicity, and economic standing. Okay? Know those terms, guys. Know the difference between religion, culture, ethnicity, race. Look at your key terms and know those differences, okay? Know those differences. Again, guys, that's religion, culture, ethnicity, race. Okay?
So
Know those terms.
How can do management?
Huh?
For the culture and religion and this is the point for how do management for the.
No, I'm talking about knowing the difference between the terms I'm talking about. Know the difference between religion and culture, ethnicity, and race. They're all kind of similar, right? Sometimes people use ethnicity and race interchangeably, right?
Yeah.
So know the difference between those terms, okay? This may include, guys, skipping phases of bouncing back and forth. Guys, you don't just go through this phase, boom, I lost somebody major, I lost something major in my life, boom, and I'm done. Sometimes, you know, you may start off bargaining before you get to anger, before you get to denial. You know, so being able to recognize these phases will make your emotional intelligence higher, and also you'll be better to effectively communicate with the patient. Okay. Regardless of the patient's process, the sonographer should be supportive. You know, because people are gonna be crying on your shoulder. These women will be crying on you. These guys, they'll be crying on you. You know, because you're gonna build that kind of relationship with them because you're with them 30 minutes. So you're gonna kind of be talking. I hope you're gonna be talking to your patient, making them feel comfortable doing the exam. You know, so you're gonna kind of build that trust with them. All right. So when they're crying on your shoulder, you know, yeah, I don't mind. I'm having a great day. Yeah, I'll be a shoulder to lean on. I got you. I got you. Love you. All of that. All of that. Okay. So talk about communication. It's a major component of sonography and patient care. Communication is the exchange of thoughts, ideas, and information. Okay. This includes listening, observing, speaking, and writing. Okay? To effectively communicate, one must be aware of one's own feelings, values, and attitudes, which may cause bias or discrimination. Guys, try to eliminate bias and discrimination when you're dealing with the patient, because they may be different than you. They may be a male and they may be a female and I'm a male. They may be white and I'm black. They may be short. They may be tall and I'm short. You know what I mean? They may be big. Some people see a big person, big body habits. They're like, oh man, I got this big old person. You know, don't be biased. Don't be biased. Because just like we learned today about the spleen, it don't matter your size. that spleen, it could be different based on the person. A bigger person to me is easier to see some anatomy, spleen, kidneys, liver. I'm just have better, the only thing I like a skinny person for is blood vessels and doing aorta, So don't just judge anybody or have your inert biases against people. Think again about your personality type as analyzed in chapter 2. This can affect the manner in which you communicate, your personality, But don't just get locked into your personality. I'm an extrovert. I gotta be wild and crazy and loud. I'm orange. I gotta be spontaneous and random. You know what I mean? I'm blue. I gotta be all in my feelings, right? So don't just get locked into your personalities, all right? It's good to know the other personality and try to adapt some of those things. So, guys, everybody read my picture, right? Read my little comic strip. So, the doctor or whoever, the tech, is over here looking on the screen, right? Reading whatever. He says, "Wow, your cholesterol really has me really worried." Meanwhile, the patient over here got arrows in his head, his chest, stomach, and then the wife says, like, "Uh-oh, hey, you might want to actually look at the patient." That's something major. That's bad communication, right? Like I told you, and I hate to use the same, but when I go to the doctor, I'm not even gonna use the name no more. Y'all know who I'm talking about. When I go to the doctor, I told you, the doctor talking to me and his hand on the door, like, "Oh, okay. Yeah, we'll get you the labs. Oh yeah, we'll send you radiology. You good? Anything else? All right." That's kind of how that feels when you don't feel important. That's how the patient feels when you don't feel important to them. They just feel like, "Oh, I'm just another number. I'm just another abdomen. I'm just another exam." So definitely make your patients feel important, and the way you can achieve that is through effective communication. Okay. So guys, there are 5 elements of communication. Again, this is something we learn in psychology, right? Refresher. Our 5 major elements include, we gotta have a sender, person sending the message. This is our sender right here, sender. And then we gotta have a message, Message could be verbal or nonverbal. When Jasmine gave me her message that, I don't know about that, JT, I could see that she was sending me a message. So me as the receiver, I had to decode her message, which is what I did. All right? And so what I did, I gave her feedback of what I thought it was. Like, "What's up, Jasmine? Like, why are you looking like, why those eyebrows at the top of your head like that? What's going on?" So that was my feedback. And context, guys. Context is just the area that you have the communication in, or the relationship you have with that person you're communicating with. Us being patient sonographer, right? Okay. Any questions? Just know those 5 major elements, guys. Know those 5 major elements of communication. Right? So let's talk about effective communication, guys. Effective communication in healthcare is the creation of meaning in communication in which both patient and healthcare practitioners exchange information so that the patient can actively participate in his or her care. Effective communication can, increase the respect for autonomy we have for our patients. The more they know, the better the decision they're able to make about their own healthcare. Okay? So, some of our forms of communication include verbal communication, nonverbal communication. Those are the main 2, right? Verbal and nonverbal communication. But also there's written communication and visual communication. For example, visual communication, charts, graphs, maps. Verbal, face-to-face, telephone, talking communication. Nonverbal is communication without talking. Okay? And written, of course, you know what that is. Written communication is right in front of you, your text. Okay? So, let's talk about the forms of communication. Let's talk about nonverbal communication, guys. Nonverbal communication is actually the overwhelming majority of communication is nonverbal. Okay? You see, like 65%. When you think about people, you always, like for instance, when I look at you guys, when in the classroom from up here, I'm always looking to see whose eyebrows are raised, because I can see the concern, I can see the question. That's why I say, what's your question, Adler? I may ask you that just based on how you're looking, just based on your nonverbal communication that you have. Okay? So, nonverbal communication includes grooming, how you groom yourself, clothing, gestures, your posture, and there's also a few more examples in the book, okay? Nonverbal communication is divided into three rungs, or three different types of nonverbal communication include kinesics, which is body language, proxemics, which is personal space, and touch, which is two forms of touch, and we'll kind of elaborate on those in 1 second, okay? The demonstration of respect plays an important role. Look at the main thing about communication is always trying to display respect to your patient, whether it be verbal or non-verbal. You always want to show the patient that you respect them, right? Okay? So just looking at all of these different forms, these are all different forms of non-verbal communication. All these movements right here, you know, we can just make our own assumption about how these people are feeling based on those movements, right? Okay? Same thing right here, even though they tell you, you know, you see somebody's eyebrows on top of their head like that, that means they're probably surprised, you know? So, you know, definitely be aware of take cues from people when they're displaying nonverbal communication, because everybody won't be able to talk to you guys. Some people can't talk. You know, just like we know that this right here, this the universal sign for choking, right? You learn that, well, you'll learn that in a few weeks when you go to CPR. This is the universal sign for choking. I can't communicate that with you in words, but when you see somebody doing this, you know they're choking. Okay? So just take those cues from the patient when you push and you know they look like you're hurting them really bad. Take that cue. Don't just continue I'm sorry, sir. I'm sorry, ma'am. You know, don't just keep doing that. Find another way. Apologize for sure, but then see if you can find another angle. All right, guys. So, real quick, I want to elaborate a little bit on our nonverbal gestures. The reason I put this slide on here is because I noticed on my test questions when I was making my test for this chapter, it covers some of these things. So, gestures and body language may be perceived as positive and negative depending on your culture, right? Or your background. You know, it's like this picture displaying. She wants to shake this person's hand. That man is bound. Everybody doesn't greet the same way. All our hand gestures don't mean the same things. You know, just like the thumbs up doesn't always mean it's good in America, but it may not be good somewhere else to give somebody a thumbs up.
This means number one.
The thumb means number one. See? Somebody can take that as something different depending on their culture, right? So let's talk about some good body language versus some poor body language. So good body language would be talking to the patient at eye level. You know, if that person's sitting down, you know, Mr. Sear, you sitting down, I'm not gonna be blah blah blah. I'm gonna be like, yeah, Mr. Sear, so tell me about it. Tell me about your pain. What's going on with your pain? Where is it at exactly? How long have you had it? You know, I'm gonna ask these kind of open-ended questions so the patient can give me feedback. Not just gonna ask a one-word question. Are you in pain? Yes, they in pain. They wouldn't be here if they wasn't in pain, right? So definitely try to get as much information from the patient as you can. Talk to them at eye level. Okay? Same thing with kids. If I'm talking to a child, I'm gonna get down on me like, hey, what's up, little bro? You know, what's going on with you? We about to get this exam done, blah, blah, blah. You know, I'm gonna talk to them on their level, you know. All right? So maintain eye contact, guys, 60 to 70% of the time. Yeah, I can be in my computer talking to you, putting information in, like, yes, ma'am. So, Lauren, tell me about your pain. Tell me something. You have it's intense? Yeah? Okay. How long have you had it? 2 days? All right. This your first time getting ultrasound from me?
Yes.
Notice I'm not giving the patient my teaching 100% of the time, but the book says 60 to 70% of the time. The book says 60 to 70% of the time. All right? All right, keep your head upright. It goes without saying. I'll talk to somebody with your head down like this. Of course not. Okay? Lean forward like this lady to show interest. You know? Get those head nods like, interested. Okay. All right? And keep your legs still. Somebody can see your leg tap and they can see that as being nervous. You know? And then the confidence in you go down. You know what I mean? They may not have as much confidence in you because they perceive you as being nervous. So keep your legs still. Okay? Poor body language will be crossing your arms, of course, to make it feel like I'm closed up. You know, I'm not really worried about what you're doing. I'm saying even though with me, I always do this. I always talk with my arms closed, and it doesn't mean anything, but the perception. When we talk about perception is everything.
It's mean you cold.
Okay? Huh?
It's mean when I'm cold, I do that too.
When you cold, you do that? Right. You know, and that's why a lot of times, when I'm talking to a patient, I stand just like this, my hand behind my back, let them know you got everything. You got all of it, all my attention. Okay? Tapping your fingers, that can be a distraction. Of course, don't do that. Frowning. Remember, your facial expressions, you know, that's all a patient gonna see when you're doing an exam, right? Because they're laying on their back, looking right in your face. What do you see? Hey, what you see? Why your face change like that? Did you see something? Is it bad? How long I gotta live? Right. I'm telling you, the question will come out of nowhere. Okay? And of course, guys, don't look at your phone. That's crazy. Don't be in there like 1 second. Okay. Now, tell me about your pain. Can you prioritize your phone over there? Right? So don't do that. If you gotta get your phone, step out. Excuse me, ma'am. I'll be right back. Ms. Ann, I'll be right back, okay? So our other two forms of nonverbal communication, guys, proxemics are personal space. Guys, that's okay. 2 to 3 feet is a comfortable distance to communicate when you're talking. Don't be all, we already on top of them when we're scanning, right? And we're gonna explain we have to do that. When you're talking to somebody, don't be all in a mix, like, you know, that's uncomfortable. That's gonna make me go like this. You know, then both people are uncomfortable, right? Okay? So remember, 2 to 3 feet is an acceptable distance. Even when, say, we're walking down the hall, when I go and get my patient, you know, you don't have to walk shoulder to shoulder with them, you know. Just, you know, walk a couple of feet away from them and just kind of have general conversation until you get them into the room, and then you can ask those personal questions. Show me your ID, you know, tell me about your exam, tell me about your pain. You can ask those personal questions when you get behind the door. Please don't ask those personal questions as you're walking down the hallway. So yes, ma'am, Miss Pat, we're gonna do your right breast. I know you had stage 3 cancer on it last week in the middle of the hallway. We're doing a follow-up, okay? So be careful with that, okay? And last thing, guys, is touch. We have task-oriented touch and effective touch. Guys, task-oriented touch is just you touching the patient in order the touching you need to do your job. Putting the transducer on their body, helping them get down to the stretch or get up from the wheelchair to the stretch. That's all task-oriented touch. I have to touch that person in that manner because I need to do my exam that way. Okay? And we also have effective touch. That kind of touch involves sentiment. You know, making your patient feel comfortable, making them feel relaxed. You know, hey, Uber, it's gonna be all right. You know, it was just one question on the exam. You'll be all right. You know what I mean? So that's effective touch right there. That's not what it is. That's effective touch. So just know those 2 types of touch, okay? And again, guys, the demonstration of respect plays an important role to how the patient interacts with you. All right? Those are non-verbal communication right there, guys. We're clear? Golden. All right? Let's talk about verbal communication, which is just plain and simple. Spoken communication, guys. Trust between the patient and sonographer comes from the sonographer's ability to initially establish a successful verbal dialogue. God, this is where I have a slide on here about aided. This is where aided comes into play. I will be testing you guys sometime this week, maybe Thursday, on aided. So be working on your aided, because you're going to have to demonstrate from the shepherd and I. Okay? Remember I gave you my demonstration about my aided? We'll talk about it in a little bit, about aided. My acknowledge, my introduce, hey Uber, how you doing? I'm JT Noiseworthy. We'll talk about it. It's not in the book. It's not in the book. I'm going to come to it. Okay? Verbal communication techniques are separated into therapeutic and non-therapeutic communication. Therapeutic is, aimed at accomplishing a particular objective. Guys, in the book, table 9.1, know those 2 tables, 9.1 and 9.2. It talks about the different therapeutic verbal communication techniques. For example, some of my therapeutic techniques in which active listening is a requirement. It's critical when you have therapeutic techniques. Okay? That's what we want. We always want to focus on our therapeutic verbal communication. All right? That includes asking closed-ended questions. Often quick yes, no. But it also includes closed and open-ended questions, right? So asking somebody, hey, have you had your gallbladder removed? That's a yes or no question, but it's also important to the exam, especially if they have elevated alkaline phosphatase. You know what I mean? Especially if they have an abnormal labs, or especially if the doctor doesn't know that the remember I told you I got called out at 3 in the morning to do an exam on a gallbladder when the patient didn't even have a gallbladder. You know, haven't had a gallbladder in 20 years. So I got called out for nothing. So that's a good example of a closed-ended question, you know. Open-ended question, that encourages embellishment. That's gonna have the patient tell you more more about what they're going through. Okay? These are all examples of therapeutic communication right here. Okay? Paraphrasing, restate what the patient says to demonstrate that you're listening. Oh yeah. Man, I've been having pain in my stomach for about 3 weeks. 3 weeks? You know, that's embellishing. That's to be paraphrased. All right. Clarify it. Avoid misrepresentation, guys. It's not on the slides. I'm coming straight from the book with this. I'm coming straight on page 255, 9192. Those tables. Okay. It avoids misrepresentation or misinterpretation. You know, make sure the patient know what you're talking about. Don't assume, guys. Remember we were talking about healthcare literacy. Most people, I told you, most people read at, you know, a 10th grade level. You know, all of us, you know, you speak above a 10th grade level. So sometimes you'll be speaking over people's head using your medical jargon, using your ultrasound terminology. You know, just in general conversation, everybody don't understand, you know, so I would say don't dumb down, but speak more generalized when you're speaking to the patient. All right? And silence. It allows time for thinking and may stimulate more conversation. Okay? If you shut up and listen sometimes, the patient may talk more. All right? So those are examples of therapeutic communication, which is aimed at accomplishing a particular objective. Could be just finding out more information. All right? Non-therapeutic communication can block or hinder effective verbal communication. And some of those examples include making false promises, right? What's that? What principle of ethics is that? Making false promises.
Fidelity.
Okay? Using cliches like, I mean, it could be worse. You could have stage 4 and not stage 2, and not stage 2. That'd be the bad thing to tell a patient, right? You definitely don't want to do that. You know, avoid using it. Well, you know, I don't know, what's another cliche? You know, the grass is greener on the other side, or you know my cliche statements. You know, I can't even think of none. I don't know when I'm on the spot. I can't think of none. Okay?
Glasses half full.
There it is right there. Think of your glasses half full, not half empty.
Yeah.
You know, stuff like that. Okay? Disagreeing with the patient can intimidate the patient and make him or her feel irrational. Okay? Guys, don't ever take away your patient's autonomy. Always let them have the final decision in their healthcare. All right? Demanding an explanation, changing the subject on the patient, patronizing, that goes without explaining. Don't patronize your patient. And giving advice. We don't give advice. That's not my job to give advice to the patient. Okay? Anything that negatively affects the communication process is referred to as noise. So sometimes non-therapeutic communication can provide noise. Noise also includes, guys, the outside noise. Like at Bentab right now, they're doing construction on the opposite side of the ultrasound. So all you hear is hammers and drills and tools all day long. You know, it can affect, you know, the communication, because then you got to speak louder, you know, and then you got to keep apologizing for that noise. All right? So I would say know those charts. You don't have to know them like word for word, but just know those different kinds of therapeutic and non-therapeutic forms of verbal communication. Okay? All right, guys. So we're done talking about verbal. Not done for the day. Not done for the day. We got plenty more slides. All right. But now we're gonna talk about potential barriers to effective communication. I'm gonna kind of breeze through those, guys, because they're on table 9.3. They're on table 9.3. Okay. So differing populations of patients have special needs to be met for effective communication. Certain emotional or physical states can act as communication barriers. Guys, if I'm dealing with a patient with altered mental status, no matter how much I talk calm to them or try to be relaxed, that patient just you know, could be on drugs, could just be crazy, you know. So it doesn't matter what some patients you can't bring down. You can't satisfy everybody. That's one thing we all have to accept at some point. Is that some people, they're gonna come to you, they're gonna be mad regardless. You know what I mean? They having a bad day. Sometimes, no matter how many hoops I jump through to make them smile, they not feeling it. And so I'm just gonna chill, get my exam done. And, all right, thank you for coming to Harris Health. You have a healthy day. You know, get them out of there as soon as possible. Okay. So language differences could also create a barrier, guys. So if the language barrier is, some people, I remember when I seen just graduated, she's Chinese, her accent's super thick, you know. Sometimes you can't understand what she's saying. So, you know, she worked on slowing down the speed of her speech so we could get the words or whatever, you know. Because when she gets in the form of people, or, you know, she gets the people she don't know, she gets nervous, and then all her words sound like one word. You know, she was talking real fast. Okay? So, but if you ever come to that where a patient, I speak English, you know, my patient speaks Spanish or anything else, and my Spanglish isn't working, my little Vietnamese, I know it is not working, get an interpreter. Get an interpreter. Always make sure your patient knows exactly what's going on with the exam. All right. Okay. Avoid referring to patients with using colloquial terms such as honey or baby. You know, you guys will see that in the clinic where, you know, people just can't help it. Especially, you know, in my culture, especially all black women, they gonna call everybody sweetie, baby, honey. It don't matter who it is. So avoid using those terms of endearment, you know, and keep it professional. Okay, Mr. and Mrs. do just fine. All right. And I'm telling you guys, and I use terms like that all the time. That's just how I speak, but I gotta be more aware. Okay? Avoid using profanity. You're gonna see it's a tech out there that curse in front of the patient. The parent and the patient cussing back and forth. You know, it's funny, but then at the same time it's not funny. Like it's serious business. So don't use profanity around the patient. Avoid overuse of medical jargon, of course. You know, don't talk over the patient. Don't talk over their heads, so they don't know what you're talking about. Make note that incongruence or non-agreement in verbal and nonverbal communication and address it supportively, particularly if the behavior is not in line with the consent. So you have the patient laying on the bed, but man, I can clearly see that this patient really, you know, maybe they felt, you know, and this will happen, guys. Maybe they felt intimidated. There's a female patient, maybe she felt intimidated when I came to get her because I was a guy, and she just went along with the exam just because, you know, I'm a guy. You know what I mean? And so she laying on the bed, really don't want this exam done. You know, make sure, because you talking to the patient is a continuing thing. You gotta keep assuring them, keep talking to them during the exam. Hey, are you doing all right? You tired? I know I had you breathing a lot. I apologize for that, holding your breath, but I need your breath to be held so I can get clear images. You know, you may have to reassure the patient as you're doing the exam. Okay. So the sonographer must learn about the cultural makeup of patients. Okay. This is really important because this comes with time. Like I said, the more you work with different groups of people, the more you learn about them. You know, and you learn not to take stuff personally. For example, you know, me being a guy, of course, it's a lot of you know, I don't want to just label all brown people Indian. Some Indian women that come, they don't want a guy doing the exam. You know, I'm not gonna take that personal. All right, ma'am. You know, but you do have to wait on the next female. We do have a female, but you have to wait on her because she's busy with another patient, right? So I'm gonna give her the explanation that, you know, I'm gonna skip you and go to the next person, but you have to wait because, you know, you wanted a female and they're unavailable right now. And it's okay, guys. My guys up here, it's okay. If, you know, somebody, same thing with you ladies. Somebody don't want you to do the exam. All right, I'm gonna go to the next person. Don't take it personal. Don't take it personal. Right? You must have respect for all cultures and be sensitive to the patient's cultural differences. The process of cultural competence involves understanding one's own culture and being able to accept and interact effectively with people of different cultures in the healthcare setting. I think we do that every day. You know, everybody in here, you know, we're all pretty mixed up in here and just learning about, I'm sure when y'all at lunch, just smelling other people's food, looking at other people's food, you know, seeing my man Dewey bring the chopsticks every day. You know what I mean? So, just being accepting of other people's culture, it help you get